Greetings. I'm Eric Eller, President of the African American Men of Westchester. AAMW is a not for profit organization which was founded in 1987. Our membership is made up of African American men who have distinguished themselves in the fields of education, finance, law, government, engineering, business, real estate, technology, and a wealth of other civic and community activities. We at AAMW believe that partnering with those organizations and individuals who share a similar vision and goals to ours. AAMW is committed to developing and encouraging collaborative action to strengthen the economic, social, and educational foundations of our communities. This is the second health and wellness webinar where we are looking to share information and knowledge on the prevention, detection, and treatment of colon cancer. We are partnering again with Mecca Santana Mitchell, Senior Vice President of Diversity and Community Engagement for Westchester Medical Center. Mecca.
Fellow participants and our audience members, my name is Mecca Mitchell, and I am the Senior Vice President of Diversity, Inclusion, and Community Engagement for the WMCHealth Network. We are a 10-hospital system spread throughout the Hudson Valley region with sites here in Westchester, Rockland, Orange, Dutchess, and Ulster counties. I want to thank Eric and the African American Men of Westchester. We are so pleased to be here with you again for our second installment of our virtual series in partnership to truly create sustainable health in the communities we serve. Now, our last session focused on the COVID pandemic and the devastating impact that it had on our communities. Today, we're going to be exploring another health-related threat that has also had a significant impact on the African American community, and that is colon cancer. Now, colon cancer has been in the news lately due to the untimely loss of African American actor Chadwick Boseman, who is famously known for playing the Black Panther in the Avenger films. While he was only 43 years old and seemingly was the pillar of health and strength, he was unfortunately struck down by a disease that significantly impacts diverse communities. Here today to share important information about colon cancer in an effort to educate and raise awareness is Westchester Medical Center's very own Dr. Edward Lebovics. Dr. Lebovics, who has so many credentials and letters behind his name, I can't mention them all, but he is the section chief of gastroenterology here at the medical center. I'd like to just add that from its inception, when the death of Chadwick Boseman was announced, immediately when we connected with Dr. Lebovics, he recognized the importance of this issue. He immediately cleared time on his calendar to plan, to create a PowerPoint with information that he knew would be useful to the communities. And he really is a champion when it comes to fighting and preventing colon cancer. He and his team have been phenomenal in this effort, and we're just so happy to have a clinician of his caliber here at our organization. Today, helping me facilitate this session again will be the the co-chairs of the Health and Wellness Committee for the African American Men of Westchester. We have Hassan Bilal and Edwin Bowman. Mr. Bilal is the president of the Bilal Group, a wealth management firm located in Tarrytown, New York. And Mr. Bowman is the founding principal of Bowman Becker Consultancy, a firm dedicated to human resource management. He is also an adjunct professor at Manhattanville College in the Department of Economics, Management, and Finance. And with that, I will turn it over to Dr. Lebovics, who has a presentation for us to be followed by questions with both Hassan and Edwin.
Okay, thank you so much, Mecca, and I want to thank everybody for taking the time to participate in this session. I always like to say that when I talk about colon cancer, colonoscopy in a social setting, my wife usually reminds me that For you, this is what you do, but for everyone else, it's very unpleasant. So I understand that people approach us with a degree of hesitancy, but it's very important for all of us, and I appreciate everyone taking their time and their interest in this. So we're going to be talking today about preventing colon cancer, and if I summarize in one picture what the take-home message is, it's don't delay colonoscopy. As Mecca pointed out, unfortunately, it takes the terrible occurrence of the passing of a celebrity in young age to bring this to the attention of many of us. And we all experienced that recently with the passing of Chadwick Boseman. And this highlighted two very important features about colon cancer screening. Number one, the increased prevalence in people younger than the age of 50. And number two, the increased prevalence in the African-American community. So we're going to touch upon those. So let's dive right into it. What is the colon? The colon is this organ here, also known as the large intestine. It has a length of about 5 feet, a diameter of about 3 inches, excuse me, and has a fairly simple function of water absorption. If we focus on that a little bit, about 9 liters of fluid go through the digestive tract in a day, and it's really only about 1 liter that is absorbed in the colon, but that's the difference between having a formed stool and profuse diarrhea. So if the colon is not functioning, life becomes rather unpleasant. Now, cancer of the colon, just to give you some information at a quick first glance, it's the second leading cause of cancer-related death in the United States. The average risk in the population is 1 in 20, but as we'll see, that varies widely depending on risk factors. 90% of cases occur in people over the age of 50, but that means that 10% are under the age of 50. People with a first-degree relative who has colon cancer have a 2 to 3 times risk of developing colon cancer. But as we'll see, most cases occur in people who have no family history. And there are currently over 1 million colon cancer survivors in the United States. So this is a conquerable condition. Looking at family risk, family genetics for a moment, 10 to 30% of cases will have a family history in a first-degree relative. But about 2/3 of cases are sporadic, which means there is no family history. And this is a main reason why colon cancer screening is recommended for the population at large, regardless of family history. Now, there are some rare hereditary genetic syndromes. The most common is called the Lynch syndrome, or hereditary non-polyposis colon cancer, accounts for 2 to 3%, and familial adenomatosis polyposis, less than 1%. So most of the cases we see are sporadic. 10 to 30% have a family history. Can we do anything to reduce the risk of colon cancer? Well, there are modifiable risk factors that are associated, and these can improve one's overall risk. Exercise is good. Eating healthy fruits, vegetables, whole grains is good. Smoking is bad. Drinking alcohol more than moderate is a risk factor, and obesity is a risk factor. Regular use of aspirin or nonsteroidal and anti-inflammatory drugs may decrease the risk, but I would emphasize that nobody would recommend that one take these strictly for the purpose of reducing the risk of colon cancer, because the risks outweigh the benefits. And there's some data that calcium, folate, maybe selenium decrease the risk. But the most important point from this slide is that with all of these modifiable risk factors, they may be important on a population basis, but none of them should be grounds for minimizing the need for screening. So one should not say, well, you know, I'm in good shape, I exercise, I eat healthy, I don't smoke, I don't drink, I'm not obese, so I don't really need to be screened. That's absolutely not true, because all of these modifiable risk factors do not modify the risk sufficiently to avoid the need for screening. Now, if we look at the trends of colon cancer incidence in the United States, we have some encouraging information and some alarming information. The encouraging information, and this axis here is logarithmic, so you can see here in the highlighted section that colon cancer over the age of 50 is plummeting, and that is directly related to our screening efforts in this population. On the other hand, we see in the lower part of the graph that the risk in persons under the age of 50 is increasing. I would still point out that it's quite rare. You could see on a logarithmic basis, so you know this is 1 case per 100,000, this is 10 cases per 100,000. Up here we're talking about 100 to 1,000 cases per 100,000. So it's still quite rare, but there is an increasing trend of colon cancer under the age of 50. Part of this alarming trend is that when the disease is diagnosed in younger persons, it tends to be more commonly at advanced stage. So stage 3 is a stage where there's already lymph node involvement. Stage 4 is where there's distant metastases. Is this because patients are not screened and we're just picking them up later? Or is this because the biology of colon cancer in young persons is more aggressive? Not really known, probably both. Why are we seeing this increase? Well, some people have suggested it's because of the trend in the United States population of high carbohydrate diet leading to obesity and diabetes, high fat in the diet. But the truth is the data is quite conflicting and the answer is not yet known. What should we be doing about this? Well, the numbers are not adequate yet to say that we should be screening across the population of adults. The incidence is still quite low, but we should be very attentive to early symptoms. So unfortunately, I have seen people who went to their doctor age 30 complaining of blood in their stool, and the doctor thinking that, well, such a young person can't have anything too serious, reassure them, well, it's just hemorrhoids, and in fact, that's not the case. So any persistent symptom, change in bowel habits, bleeding, bloating, pain, should be evaluated further, and we should be more aggressive in this age group than we have in the past. What about the data in African Americans? Let me summarize it for you. The prevalence of colon cancer in African Americans compared to other ethnic or racial groups in the United States, African Americans have the highest frequency and the highest mortality, which is rather alarming. And for that reason, some of the societies that make these recommendations recommend that colon cancer screening should begin at age 45 in African Americans. And in fact, the American Cancer Society says age 45 across the board for all Americans. But certainly in the African American population, age 45, I think, is very appropriate. Screening in the African American population is less likely. In other words, adherence to screening recommendations is lower. And as such, African Americans are less likely to have polyps detected at a stage where they can be easily removed. And when colon cancer is diagnosed, it is more commonly diagnosed at advanced stages. And of course, that will translate to the fact that African-American patients with colon cancer are less likely to survive 5 years or more after diagnosis. Again, we can ask, is this due to lack of screening and late diagnosis, or is this due to a more aggressive biology? Probably both. So there is data. I should mention this is a very difficult area to get reliable data on, but there's data that suggests that there are modifiable risk factors that are more prevalent: obesity, smoking, alcohol. There are genetic factors, and there is definitely a lack of equal access to healthcare, leading to a less adherence to screening guidelines. It's important to note that women have the same prevalence as men. So sometimes women are less likely in some populations to get screened, and that is not appropriate. And there's a greater probability of right-sided colon polyps in the African-American population, which underscores the need to have full colonoscopy, and we'll talk about that in a little bit. So let's talk about screening. And here, I just want to quickly share with you the principles of screening. When medical societies recommend screening, it's based on very reliable and important data. And it's not uncommon for a patient to come in and say, doctor, could you just get a CAT scan on me from head to toe? And we will have to explain to that patient why that's really not a good idea. So what is the basis of a screening recommendation? There are several conditions that have to be met. Number one, it has to be an important health problem, right? Doesn't pay to screen for trivial issues. There has to be a latent or early symptomatic stage during which the condition can be picked up before it's a problem. If you could only pick it up at a late stage, there's really no point in screening, of course. We need a test with a high level of accuracy. If we're going to have a high false positive rate, sometimes that will lead to more complications than benefit. We have to have an effective treatment. To screen for something that we can't treat also doesn't make sense. And then logistically, we have to have available facilities to do this, diagnose and treat, and it has to be cost effective. So in the case for colon cancer, really fulfills all of these. And that's based on the adenoma carcinoma sequence, also known as the polyp cancer sequence. And what that means is from normal colon lining tissue or epithelium to adenoma or a polyp to cancer and invasive cancer takes a period of 10 to 15 years. So if one makes the diagnosis anywhere before here, that window gives you the opportunity to offer the patient treatment by removing these polyps and thus preventing colon cancer. And this is what it looks like under a microscope. And this is what it looks like through a colonoscope. This is a small polyp, a larger polyp, a large polyp, and then unfortunately a cancer. Now there are exceptions to the rule. The most common being patients who have colitis, whether it's Crohn's or ulcerative colitis, so they can get colon cancer that develops in non-polypoid or flat lining tissue, and we screen them in a completely different way. So that's really an exception to the rule. But for the general population, this is what applies. So how do we screen for colon cancer? These are the options, and they can be divided into two categories. The first category are tests that find polyps and cancer, and that's preferred. We'd like to be able to find pre-malignant lesions, remove them so that the patient never develops cancer. And then we have tests that mainly find cancer. Of the tests that find polyps and cancer, so colonoscopy is preferred. Colonoscopy is the insertion of a flexible tube that has a video chip on the end and allows the endoscopist to visualize the whole colon. It requires taking a colon preparation prior. It is done under sedation and is very sensitive to finding small polyps that are removed at the same time as the procedure is done. And it's extremely safe. An up-and-coming modality is CT colonography, which is a very specialized form of CT scan. I will show you that. The computer reassembles the colon and is quite sensitive for small polyps. It does require a prep. It does not require sedation. Unfortunately, it's not widely available. It is available here at the Westchester Medical Center, but it is covered by insurance really only in very limited circumstances, such as patients who cannot have a colonoscopy or patients in whom colonoscopy was not successful. Flexible sigmoidoscopy and barium enema really are not regularly done except in areas where there just is not adequate access to colonoscopy. Now, there's another alternative for screening, and that is tests that mainly find cancer. And these include a fecal occult blood test, testing the stool for blood. And the patient submits a small stool sample on a card, which is chemically tested to see if there's blood in it. And that can be done in a more sensitive fashion with an immunochemical test. And more recently, there's a stool DNA test. The test that is marketed, I'm sure you see advertisements for it, as Cologuard, is the combination of a stool DNA test and a FIT test, and it is currently recommended every 3 years. It is sensitive for colon cancer, but not very sensitive for colon polyps. But again, I would emphasize, while we think colonoscopy is the best test, any test is better than no test. So if a patient is reluctant to have the preferred test, they should have some test. To do nothing is obviously the worst strategy. Let me show you here the difference between colonoscopy and sigmoidoscopy. So here we have a color-coded colon, and you can see that colon cancer occurs 20% of cases in the rectum, 25% in the sigmoid colon here in purple, 15% in the descending colon in orange, 10% in the transverse colon in, I guess, pink, and, well, not sure what color that is, and 30% in the ascending colon in lighter purple. Now, sigmoidoscopy will only examine this green section here. Colon, and is done, the advantage being that is done generally without sedation. Full colonoscopy will go through the entire colon. So that's why I emphasized earlier, if one wants to see right-sided colon polyps or colon cancer, one needs to do a full colonoscopy. And again, in the African-American population, the prevalence is higher for right-sided colon polyps than in other groups. So we really don't recommend sigmoidoscopy as a screening test. It's been compared to screening a mammography only on one side rather than on both sides, which really makes no sense. So if we compare the features of the main screening tests, you could see that colonoscopy and CT colonography are very sensitive for adenomas as small as 10 millimeters. The main difference being that colonoscopy requires sedation, but offers therapy at the same time, whereas colonography requires the patient coming back another time for the polyps to be removed. Colonoscopy is, of course, widely covered, whereas CT colonography is covered by insurance only those limited circumstances. Both are extremely safe. The risk of colonoscopy is about 3 in 1,000 of significant complications. The stool DNA test is 92% sensitive for cancer, but only 42% sensitive for advanced adenomas or premalignant lesions. So here's just a picture of how we do remove polyps. This is called a pedunculated polyp. It has a stalk. one positions a snare over the stalk and then removes the polyp, usually with electrocautery to seal the stump. Flat polyps can be removed in the same manner, or if they're very large, by injecting under them to lift them up and then snare them off. And these are done again at the same session. Very importantly, colonoscopy is the only modality that has been shown in this landmark study in 2012 to actually decrease the risk of colon cancer death by doing polypectomy or removing polyps at the time of colonoscopy. So here you see the expected mortality from colon cancer from the general population. And here are patients who had adenomas removed, patients who had no adenomas removed, who had no adenomas. So you see that there's a significant decrease in the number of deaths in patients who have had colonoscopy. This is a picture of CT colonography. So you can see the CT picture, which here is showing a small polyp. This is the valve to the small intestine. And here's how the computer recreates a picture that looks very much like a colon and outlines this polyp. And again, a recreated picture of a colon to emphasize that in some cases, just because of all of this curvature, one may not get a good look unless you were pointed in that direction by the colonography. So, a very important issue is getting people to comply with the need for colonoscopy. And while I think I've explained to you why it's so important, for some reason, the image in some people's mind of colonoscopy remains something like this, and they just can't, for some reason, deal with it. And, there's data on this. Why do people not comply with the need with screening colonoscopy? Fortunately, the lack of recommendation is now quite uncommon amongst primary care physicians. Lack of insurance is quite uncommon. Here at Westchester Medical Center, even uninsured patients are offered colonoscopy through charity care. There are issues with embarrassment dealing with that orifice, apathy, denial, fatalism, and people who just don't want to go through the bowel prep or have fear of pain, sedation, or complication. But I think it's important for primary care physicians, as well as people who are friends and relatives of candidates for colonoscopic screening, to address these and speak to patients about it and have them deal with it in a educated and a rational manner. It's important that colonoscopy done by an expert, and we have report cards that tell us that a certain endoscopist is doing a good job. We look for certain scores, that the bowel preps are adequate, that they reach the end of the colon, that they have a certain success rate at finding adenomas, which should be over 25% in screening colonoscopies at age 50, that they spend enough time searching for polyps on withdrawal, and that they recommend appropriate surveillance intervals for patients who have had polyps. How good are we doing in the United States? So you can see this is from 2016 at New York State. 68% of the population complied with any form of colon cancer screening, and that includes fecal occult blood test to colonoscopy. So any form of screening, only 68%, and there's a goal to get that increased to 80%. But unfortunately, in the 5 years prior to that, there was a decrease of 1.8% in New York State. And of course, this is what we're dealing with now, coming out of the COVID epidemic. You can see this was in the New York Times. Births remain fairly stable. Can't really plan for that or avoid it. Whereas colonoscopy for screening went down to essentially nil, went down by 90% April, May, and is now coming back. We're close to our baseline levels, but you can see here there's still a 35% drop here in July compared to baseline levels. I don't think it's an issue if somebody delays a few weeks, even a few months, but if it becomes more than a few months or a few years, then that's really increasing a person's risk. So that's really what I have to say, and I hope that was informative, and I'm happy to take your questions.
Thank you so much, Dr. Lebovics. I just learned so much from that presentation alone. I'm thinking already about how I've got to schedule appointments for my husband and myself, who now both fall into the category of age and race that puts us into jeopardy. And so we will be getting that done. I'm going to now turn it over to Hassan Bilal, who I think is going to kick us off with the first question.
Yes, thank you very much, Mecca. And thank you, Dr. Lebovics, for your extremely informative presentation. I know I learned a few things I was not aware of before, and I'm sure I'm not alone. I'd like to start off with what may seem like a pretty basic question. I've heard the terms colon cancer and colorectal cancer used in various outlets. Is there a difference between the two? And if so, can you please explain?
Sure. Like in any field, medicine is no different. We have lumpers and we have splitters. Colon cancer and colorectal cancer refer to the same entity, and that is cancer within the rectum or the rest of the colon. Some people prefer to refer to it as colorectal cancer because cancer that is located in the rectum has certain differences in terms of management, certainly in terms of surgical management, the possibility of using radiation treatment, which exists for the rectum and not for other locations. Genetically, genetic risk factors, family history, they're really the same.
During your presentation, you talked at length about how one can go about reducing certain risk factors, such as only drinking in moderation and eating healthier. Can you talk a little bit more about the risk factors for colon cancer that one cannot change?
Well, the risk factors that one cannot change are one's genes. We're born with them, and there's not that much that we can do about it. And in fact, I think that's the dominant risk factor. So let me just reiterate and emphasize a few points. Number one, most cases of colon cancer are sporadic, meaning there's no family history. So in terms of what a person does, everybody across the population needs to be screened at age 50, perhaps earlier in certain subgroups, and perhaps that'll change over time. Patients with a family history indicates that there is some genetic risk factor, and they should be screened either as the standard population or 10 years earlier than the youngest first-degree relative's diagnosis. I would also emphasize that the presence of a family history of colon cancer after age 60, onset after age 60, does not really modify one's risk and does not really change one's screening recommendations. And then we have people who fit into a genetic syndrome, the most common of which is the hereditary non-polyposis colon cancer syndrome. These patients have a very strong family history, and we are able most easily on pathologic specimens to make that diagnosis and then test family members. And these patients undergo colonoscopy every 1 to 2 years and have to have screening for other non-colon malignancies as well. I mentioned the less common familial adenomatosis polyposis syndromes, and these patients also have more intense screening, and most of them unfortunately end up with total colectomies when they reach adulthood because of the very high risk of colon cancer. Fortunately, those are very rare.
Thank you, doctor. While colon cancer is said to be one of the most preventable forms of cancer, as you stated earlier, it is the second leading cause of cancer-related deaths in the US. Can you identify some warning signs so people know what to look out for and when it might be time to make a doctor's appointment?
Sure. And, as we discussed, patients who are younger than the standard screening guidelines, this becomes more and more important. So, patients who have sustained, and I would warn that because I don't want to scare people. We all get episodic diarrhea, constipation, may see a little bit of blood on toilet tissue, and I don't think that's alarming. But if there is sustained rectal bleeding, certainly any blood that is beyond what you see on the toilet tissue, change in bowel habits, diarrhea, constipation, change in the caliber of the stool, bloating, pain, lower abdominal pain, unexplained nausea or vomiting, any of these symptoms should generate a visit to the physician. Now, I would reassure people, most of the people who have such symptoms do not have colon or any other cancer. They have one of the many common conditions that cause these symptoms that are easily managed with the help of your physician. But they do require evaluation. And as I said, our threshold for doing a colonoscopy is significantly lower than in the past. And one should never just pass off such symptoms and saying, well, I'm 25, 30, what could it be? It needs to be evaluated.
Doctor, you touched on the different screening options during your presentation, but can you go into a bit more detail, perhaps in hope of making people feel more comfortable when having this discussion with their doctor?
Sure. So I think I would first emphasize that any screening is better than no screening. So screening should be individualized. If a person, for any reason, is not amenable to colonoscopy, they should have some form of screening, whether it's the most minimal, being fecal occult blood, or a Cologuard test, which is now widely available. They should have some form of screening. The discussion that the physician should be able to educate the patient about is to reassure them about what their fears are regarding screening. And we discussed some of those. Safety, and I'll speak about colonoscopy. Colonoscopy is extremely safe. Significant complications overall, 3 in 1,000, but even those are really limited to patients who have significant risk factors, such as very large polyps or a fixed colon due to prior surgery. So it's an extremely safe procedure, and they should be reassured about that. It's painless, done generally under deep sedation, which is also extremely safe. And the prep, which is the, excuse the pun, the butt of many jokes, is not pleasant, but very tolerable. As I tell patients when they come in for their procedure, the worst is behind them. And I think patients who have undergone the procedure will generally say that it's quite a tolerable experience, and are thankful that they did it.
Doctor, as you mentioned earlier, we all know that the actor Chadwick Boseman died of colon cancer at the age of 43. While 50 is currently the average age when colon cancer testing is recommended, the American Cancer Society reported that in 2020, about 12% of colorectal cancers, or approximately 18,000 cases, will be diagnosed in people under the age of 50 in the US. Do you think it's just a matter of time before that recommended age is lowered?
Absolutely. It's already been lowered by the American Cancer Society. It's been lowered with regard to African Americans for some time already by some of the societies. It's kind of a fact of life that frequently these decisions are not made by the patient or the physician. It's the insurance company that has to cover the procedure. So if I look into my crystal ball, which is not always so accurate, I would say it absolutely over time, the screening age will go down to 45 and I think ultimately lower. But right now, we pretty much have to comply with what the insurance companies will cover. Certainly if a patient has a diagnosis other than screening, then that would be solid ground to proceed at a younger age. As long as I'm using my crystal ball, I will tell you that I would think that in 10 to 15 years, colonoscopy will not be the dominant diagnostic test for colon cancer screening. Ultimately will become a therapeutic modality. In other words, we will have other modalities to accurately diagnose colon polyps and colon cancer, and patients will undergo colonoscopy just when they have polyps that need to be removed. But I think for the immediate future, colonoscopy is the dominant screening tool.
Dr. Lebovics, while prevention is always the first course of action, we understand that everyone will not be in the clear. With the rates of colon cancer being especially high in the African American community, if a person is diagnosed with colon cancer, then what questions would you recommend that they should ask their doctor?
So when a person unfortunately has a diagnosis of colon cancer, the first step will be staging. So if the individual undergoes a colonoscopy, they find a lesion, it's biopsy, the pathology comes back as malignant. The next step will be to get a CT scan of the chest, abdomen, and pelvis to evaluate whether there's spread to any organs outside of the colon. Fortunately, I would say the vast majority of colon cancers that is picked up on screening is relatively early stage. Colon cancer that is picked up because of a symptomatic presentation, patient comes in with bleeding or pain or obstruction, then some of those are going to be unfortunately higher stage and more severe disease. So based on the CT scan, then the patient will have a discussion with the physician about what the therapeutic options are. And if it is limited to the colon, generally the next step is going to be a surgical resection. If the lesion is in the rectum, then there is a possibility in some cases that it would be treated first or maybe even definitively with radiation. So, those are the things that a patient needs to know. And I think patients should find physicians that they trust and follow their recommendations.
Doctor, can we talk a little more about treatment options that might be available? Also, do the various stages of cancer dictate that treatment may be available to a person after receiving a diagnosis?
Absolutely. So, our ability through the scope now allows us to remove, without further surgery, just at the time of colonoscopy, I would say that the vast majority, and with really rare exception, of benign lesions. So there can be very large lesions, superficially spreading, and through modalities that are called endoscopic mucosal resection or endoscopic submucosal dissection, we are able to peel those lesions off the wall of the colon and remove them through the scope, and save the patient the need for surgery. There's even developing now the ability to, through the scope, do transmural or resect the entire wall of the colon, and then again, just with a scope, sew back the wall together, and have the patient avoid surgery in certain types of lesions. So the ability to treat any benign lesion and even some malignant lesions through the scope is expanding. For patients who have lesions that have to be surgically removed, so that some of the progress that's been made is that many of these lesions can be removed laparoscopically. What does that mean? That means it's not a large incision, it's just placing, the surgeon places small scopes through tiny incisions in the abdominal wall, and through those is able to do a colon resection. And the recovery time is much diminished, and it's just as effective. And here, our colorectal surgeon frequently does this robotically. So, the ability to do colon resections much less invasively is progressing rapidly. As I said, depending on location, there may be an opportunity for radiation therapy if the disease is limited to the rectum. That's the endoscopic, surgical, and radiation options. Now, for patients who have advanced disease on diagnosis, stage 4, meaning there's distant metastases, the treatment is then going to be in the realm of the oncologist. We're talking about chemotherapy, but there's been enormous progress in that area as well. And even stage 4 colon cancer now has turned into a chronic disease. And with the monoclonal antibodies and biologic therapies that are currently available, patients can survive much longer than 5 years with even stage 4 disease. And I think that's an area that is developing rapidly as well, and I would expect there's going to be enormous progress over the coming decade, even for patients with stage 4 disease.
Doctor, what advice would you give to a person who has been diagnosed and successfully treated for colon cancer? Additionally, is there a greater likelihood of colon cancer returning, or even in another form of cancer, or another form of cancer developing later?
Sure. Let me back that up a little bit. Any patient that has had a premalignant polyp, an adenoma, will go into a surveillance program. And depending on the size and number of adenomas that patient has, we will recommend further colonoscopy anywhere between 3 and 10 years. Well, 3 and 7 years for patients who've had an adenoma, whereas patients who have a perfectly normal colonoscopy do not have to repeat for 10 years. Patients who have had colon cancer, if it's a sporadic colon cancer, it's not part of a genetic syndrome, those patients will have to have full colonoscopy at 3 years and then at regular intervals thereafter. Many of us will do a repeat colonoscopy at 1 year after the colon was cleared, just to make sure there are no other lesions. Now, patients who have a genetic syndrome, they may need more frequent colonoscopies. As I mentioned, hereditary non-polyposis colon cancer or Lynch syndrome, we do them every 1 to 2 years. Patients with familial polyposis syndromes, generally every year until they become of age that require removal of the colon. Both of those, Lynch syndrome and familial polyposis, are associated with other cancers in the body that also have to be looked for. And so they have surveillance of other organs as well, and they're kind of put into a regular surveillance regimen. Patients who have a sporadic colon cancer don't have an increase of other non-colonic cancers that need to be screened for by virtue of that alone.
Wow. Again, I am blown away by not only the information, the detail, but the fact that Dr. Lebovics, you have been clear and concise, and this information has been presented in a way that does not cause additional fear or anxiety for people. I very much appreciate the fact that the urging of people to get the screening with the understanding of how important it is when it comes to a disease that can be this fatal for this community is so important. And as you stressed, even without insurance, we encourage people to seek us out and get information about charity care options. We do not want people to delay getting these screenings. And I am one who I can candidly admit that years ago, due to some issues I was having with my stomach, I had a colonoscopy. It was nothing to be concerned about. There was no pain. There was no discomfort. And the small amount of agitation and having to do the prep work was nothing compared to the disease, if you get it, and how fatal it can be and how disruptive to your life it can actually be. So there are things that are well worth it. Getting screening and colonoscopies and taking advantage of some of those other screening tools is one of those areas. This is well worth it. And I'm just so happy, Dr. Lebovics, that you were able to take time away from your schedule to share that information with us. Additionally, as always, I want to thank both Edwin and Hassan for this partnership with the African American Men of Westchester, a partnership that began years ago and that we continue with even in this time of virtual gatherings. It's important for us to keep dialogues going about health, about wellness, about prevention, and on issues like this, which are so timely and relevant and important, we definitely want to continue to push information out to our communities that we know can save lives. And one last thing before we finally sign off for this session, there will be a slide presented that will have information about how to contact us at Westchester Medical Center to schedule a screening, how to contact us about getting more information. You can do so online, or you can call our number 914-533-4111. Again, this information is going to be presented on the slide that's going to be displayed at the end of this presentation. Thank you.